So, welcome to NUR203 Pediatric Nursing. You all are now only 1/4 away after this from graduating, getting in, most of you, into capstone and becoming registered nurses. My goal for you is to try to help you to think more, to be able to look at different things and to apply it in many different ways. And I do that in several different ways. My class, I don't know, some of you have already heard about me and the way I teach, but what I do is I would hope, if possible, and I know some weeks it isn't, but at least to have looked at that interactive PowerPoint on your modules. And that's going to give you some understanding of what are we going to talk about. Then you come to class and I have a PowerPoint and it has pictures. I do not read PowerPoints. I'm going to tell you the concepts in each slide. I also am going to bring a lot of stories of a lot of patients, children that I've taken care of to try to help you understand the information better. And then when we're done with that, we're going to do a Kahoots. Now, these Kahoots are something every single semester I change. And in those Kahoots are those concepts that you really need to understand, how to apply them in many different ways. And you'll see sometimes I might ask the same question, but in a different way, so that you think of it in a different aspect. Because you can look at a question, from different angles, and all of those angles could have a different answer to them. Now, my classes usually run about 1 hour and 50 minutes. Is it okay if I just run through the class and don't give you a break in this 2 hours? That will get you out a little bit earlier, and it also will just keep going, and you don't break that flow that you're going through. Is that okay with everybody?
Yes.
Yes.
Okay. I will make every attempt to get you out of here 10, 15 minutes early every single class. Now, there are some classes that are longer, and I will warn you about them. So I hope you all have had a chance to look at your syllabuses and know what's expected. I'm going to warn you on the first day that the end of this course, it's going to get rough, not just because of pediatrics, but because you have also Med-Surg 2, which is getting more difficult. And most of you also have community, and there's projects due at the end of this semester. So do not get behind. Now, I have 4 different things that I don't have dates. That's a start date, which means you can do them ahead. I'll warn you, if you do them ahead, do not post them until they're due, because in online nursing, you have to show that you've entered into your Canvas shell 2 times every week. And if you don't do that for 2 weeks straight, they can drop you with no warnings. These 4 people on the bottom, can you turn your cameras on? The one thing I want to see is your faces. The only way that I'll say you don't need a camera is if you message me, something's going on and you can't, etc. But I like to see your faces, your expressions, and it actually helps me teach. Now, these 4 things, Sylvia, Juliaki, and Victoria, cameras on, please. So the 4 things that are open are your NCLEX questions, your discussion questions, your Kaplan, and there is a pediatric assessment assignment. That pediatric assessment assignment is a 3-part thing. It's worth 6% of your subjective grade, and it's not due until the end of the semester, which is, I'll give you the exact date. I believe it's September 4th. It's due September 4th, and then you have another week with minus 10% to September 11th. Now, this assessment project, the one thing about it, it is worth a lot of points, but I will let you turn it into me. I will look at it, give you some suggestions to improve it, to improve your grade. You improve the grade, you send it back, let me know, and I will increase your grade. Because 6% is a lot of points that could actually fail you. I had one student who almost failed because Somehow she did not get that assignment in. So she got a 0 on 6%. And the whole semester, she did very well. So it was a close call. So don't do that to yourself. So these things you can start turning in now. Case studies, you can't until they're due because they're appropriate to the information that we're going with that week or the week after. Your dosage calc is also open for you. So there are ways I have set this up to let you work ahead, because some of you like to take the load off for the end of the semester. So that is there for you. Now, today, what we're going to do is exactly what I said. We're going to go over, actually, it's 2 PowerPoints. I'm going to go over the online information that you need to know, what's expectations. Also, we're going to go over on PowerPoint week 1, and you both have copies of the, all of you have the copy on those both PowerPoints already. And then I'm going to do a Kahoots. Now the Kahoots, I don't score it. It is a fun time. I have many students who like to compete with each other. Who's going to win this week? But what I do with the Kahoots, I talk over it. So I'm teaching you, what is the question? What are you looking for? What could be the answer? What could be another answer? And you'll understand as I get going with that. Any questions? Okay. Attendance, I do. You need to come to live sessions. I think they're important. And then I've had many students say that after the live session, you know, maybe on the weekend, they'll go over the recorded session again, just to get the information, just to be sure they didn't miss anything. Because I know if I'm sitting here for 2 hours, I'm going to doze off and go somewhere else, or thinking about, got to pick the kids up, what's for dinner. You know, I get that. So if you go back, you'll be able to fill in those gaps that maybe that you had that zone out moment. So I'm going to start with, first of all, the online information that you're going to need, so that you know what your expectations are, who to call, etc. So we, as an online team, we have, you know, all of these things set up for you. What I want you to make sure that you do is make sure, if you're running behind, life happens, your kid's in the ER, you're in the hospital, let me know before an assignment is due, and I will give you an extended amount of time. Do not ask me afterwards, okay? It's because you need to, if you were a nurse and couldn't do something to a patient, you need to let the physician know before it happens for whatever reason, okay? So who do you contact? Well, I am the lead instructor for pediatric nursing. So me is your first person of contact. If you cannot get a hold of me, you can also go to your campus dean if it's a question that they could answer, or contact the National Dean of Nursing, which is Dr. Brown. Dr. Brown does not mind being contacted. In fact, if you can't get a hold of me, please contact her. She's a very good resource and she will help you. And I don't think she sleeps, because she answers every message extremely quick. So how do you get in contact with me? Well, your first thing to do is, if it's just one of these things you need to tell me something, send me a message or an email, and that's okay. If it's something I need to know immediately, or something's happening that you want an answer quickly because of whatever reason, I have a cell phone. All I ask is that you be respectful. I'm not going to answer things after 8 o'clock at night. I'm watching a movie and relaxing for the day. You know, old ladies like to watch a movie and go to sleep at night. That's what I do. If my grandkid's here, we're watching a cartoon, and he's here quite regularly because we're best friends forever. Also in the morning, you can leave me a message. I will get back to you actually very, very quickly. The text messages I do pretty quick. Sometimes, well, grandson will steal a phone, so I won't have it as quick, but I do get back quickly. Weekends, I will answer you. Usually 12 to 6 is great times for me. I like to have a nice leisurely breakfast in the morning and relax. And then in the afternoon, 12 to 6, I'm there available for any questions you might have. So you can call me on my cell phone. My number is posted in the announcements. It's on, my bio, but I'm going to give it to you again. It's 305-594-8255. 951-8055. I live in South Florida. I live about half a mile from the Florida Keys. So I am on that Eastern time. So classes and assignments. So your assignments are Monday early morning, 12 o'clock is when quizzes opens, case studies opens, things, all of those. It closes the first week on Sunday at 11:59. If you are after that, it will be, you have another week to hand things in. And then after that week, it with minus 10%, after that, it's going to be a 0. Unless you notify me something's going on with you, and I will extend your time for many reasons. Just don't ask for every assignment to be extended, okay? This week, your first week, you do have something due. And it is basically tell me about you, why you want to be a nurse. And then it talks about nutrition. You do your first post, which is you. Make sure it has a reference. Usually it's the book. The book is a great reference. Make sure in the body of this, whatever you're giving me, this paragraph or 4 paragraphs, that you cite where you got the information from. And then by Sunday, you must respond to 2 of your peers. I do read them, and I will give you information. If it is a citation you're missing, I'll give you an example of what I am talking about. So I work with you to make sure you get better and better every week. As I said, if you're on time, you get full credit. After 7 days, it's minus 10%. And after that, it will be a 0. All online is like this, unless, again, contact me if you're gonna be late. I do take attendance myself, as I said, on Zoom, but Canvas only knows things that you put in there. And it's the attendance attestation, which I will remind you at the end of this class, please sign your attendance attestation. Tomorrow, I'll send you a message if you didn't to make sure you sign it, just to get you in the habit of it. And I'll do that for a couple weeks. It also, any submission, and you can see where those submissions are. And like I told you, you will be dropped. And I've seen it happen before because they didn't have anything posted in Canvas. This student happened to send it in an email to the instructor and they got dropped. Make sure you keep organized. Make sure that you know what's coming up week by week. Some people like it digitally, some people like it on paper. You know, I have a calendar and that's what I use, paper, because, you know, old people like paper. Young people, they're digital. Okay, not a problem. I don't care how you do it. Every exam will have a review. Now, your first exam is week 4. So week 3, you're going to get a list. Every single professor does a review. We all teach differently. It's the same PowerPoint we use for review, but you're going to get somebody else's, you know, take on it, and maybe you'll understand that. So find out who you like to listen to, and at least 2 listen to. So how to be successful, as I said, just talk to me. Let me know what's going on. Keep yourself organized and make sure you're posting as you should, at least 2 things every week. So of course, your syllabus you need to have. Make sure you come to my meetings. Now, if you can't come to my meetings, which is these Zoom lessons, let me know. I'll just tell you to do a 2 or 3 paragraph little thing on, tell me about, let's say it's next week, it's on infants and toddlers. Tell me something about a developmental stages on infants. And you just post that in the attendance attestation, okay? So that I can see at least you've probably, hopefully, have listened to that lecture. So I do review sessions. I do not do just regularly scheduled. If anybody needs any help in any subject, any concept they don't understand, come to me. If it's your campus you don't understand and there's 6 of you, come to me. We together can find a day and a time that works for you. And I am more than willing to help you understand things. All you have to do is ask. If you don't ask, I don't know. So we have the grading. How do we grade? Well, KGA is what we call key graded assignments. Unit exams, quizzes, HESI are worth 80%. Everything else is worth 20%. So make sure that you get a 78.0 on the key graded assignments, and then we add in the subjective grades after that. Now, about week 6, I am going to open up the subjective grades and show you how they affect your overall grade, just to let you know. And then I turn it off about week 9, and then we just do it regularly. So there is quizzes. They are posted. They are one time only. They are timed. They're 15 minutes, and you can only go forward. This is just like your NCLEX. So we're preparing you to be able to come to the quiz or an exam and do the question and go forward. If something happens during the quiz, a lightning storm, a hailstorm, electricity went out, your computer, the dog ate the cable, and it's, no power, whatever, let me know and I can let you redo an exam, a quiz. Just let me know. I can tell by timestamps in the quiz what happened to you. So make sure you send me a message so then I have your timestamp when exactly this happened. Very important, that communication with that timestamp. And I can show the dean, because she's going to ask, why did I let you redo the quiz? And I can explain why, and I can show her the documentation. We do our exams on Zoom with the class. And after the exam, we do have class. Now, what I have done, like for instance, week 4, you have an exam. We usually are done and we come back to class about 20 after 4. I will do a Kahoots for the information and concepts that you need. And as I do the Kahoots, I actually explain a little bit more than usual for you to understand. You will get the PowerPoints that should be attached that I should have done if I wasn't doing an exam, but I will do a Kahoots with that. Again, if you're not understanding, please ask, and I'll do the PowerPoint with you or a group of you. Okay, now there are some campuses like Cookeville that the dean will do proctor's exams. I send them the access codes and that's fine. Just let me know if you are doing something like that. I have to make sure that the campus knows who the person is, to keep the integrity of the exam. If you miss an exam, tell me before you're going to miss it. If you miss it and you haven't told me, there'll be a 10% deduction, and you don't want that. So if something happens, you can't take the exam. Remember, I do have a phone. If you're out on the road, text me, then I have a documentation. If you can send me a message from your phone, send me a message so I can see, all right, something happened, this happened, okay, let's give her the exam at another time, and we can send you to another class, or I can do it with you one-on-one. Again, I can't tell you enough. Anything that's going on with you, let me know. I can help you. If I don't know, I can't help. So the homework assignments, as I said, keep organized. Do not get behind. It's going to get rough at the end of this semester. NCLEX questions are open, but I tell you, do not submit them till the week that they're due. Make sure you do what the NCLEX questions topics tell you that they want done. This first week is on growth and development, and it's not under pediatrics, it's under growth and development, okay? That's a hint to let you know. Make sure that you submit them correctly. Don't send me a picture of completed 25. Don't send me a picture of it. I want to see that 4 or 5 page thing so that I can go down and check to see that you've done the correct NCLEX questions that you're supposed to do. If you do not know how to do it, let me know. I've got information. I can send you that instructions, or I can get on Zoom and show you. Each NCLEX question is worth 50 points, okay? You can do them as many times as you want. Try to get the best questions as you can. To tell you, NCLEX question, each set is worth 1% of your grade. So if there's 4 of them, that's 4%. So try to get the best grades as you possibly can. No remediation on NCLEX questions. When you're doing your case studies, they must be done through the modules. If you do them outside the modules, you will get a 0, and there's no way I can change that grade for you. If you do the NCLEX questions, the case studies through the modules and you get a 0, it sometimes happens, let me know right away. And submit a help ticket, because you've done it right, you've done it through the modules, you don't have a grade, and I'll do the same thing, and then we'll get your grade. All right, I said that. So again, when you're doing your paper, which is the pediatric assessment paper, or you're doing discussion questions, use APA format. Make sure you cite, and I'll be working with you for that. Quizzes and exams, again, we know quizzes are 15 minutes. It goes forward, doesn't go backwards. Any problems, technical, let me know right away, and I will help you. Kaplan is not due till the end of this semester, weeks 10 and 11, I believe they are due. So when you do Kaplan, you do not have to send me anything. I have to go into Kaplan, each campus, each student, and look it up. And remediation is due even on correct answers. So if you get 100, you still have to do remediation on every single question. 1 to 2 minutes, that's all I ask for. And I do check that. So make sure it's done. Again, if you don't do it, I'll send you a message to let you know, to try to, for you to get it. And the HESI. The HESI is once, there's no a second try on it. It's on a week 11. It will be most of you through the campus. Some are still Proctor U, but that's up to each campus. Each campus will tell you when and where and how they're going to do it. When you are done with your HESI, you'll have till Tuesday morning of week 12 to get the remediation in. If you don't do remediation, as it said in the HESI program, then you get a 0. So that's basically what's going on with pediatrics and all the little things that you need to know about it. Any questions? Okay. Let's go to week 1. I like PowerPoints, and I like them with pretty pictures. And I think pretty pictures really tells you a lot about, what I'm trying to convey here. Now, as you go on in your nursing degrees, if you go further, BSN, MSN, I never knew what healthy people was all about until I, went further on into my degrees. And healthy people is this from the government telling you what are goals. What are we going to do to improve the health of children and the elderly and of women and men, etc. When we're talking about children, our health goals and promotion is on having them develop correctly, growth and development, nutrition. Most important thing in children is nutrition, 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 and then oral health. If you have bad teeth, you're not going to be able to eat. What are some of the healthcare problems that we're seeing? Well, today, obesity, because children are more sedentary, doing video games and games on their phones, etc., and they're not out running around. And today fast foods are the easiest thing that there is, to feed a kid. And parents are busy. Today you need 2 parents to work in order to make, the ends meet. So you're always busy, so fast foods, and we know they're high in calorie. Childhood injuries. And when you talk about childhood injuries, one of the biggest injuries in children are motor vehicle accidents. Whether they're in it, they're thrown out of it, or run over a car. I've seen several children backed up over by cars, by their aunts, their mothers, their fathers. And it was one of the reasons why I've seen the development of those rear view cameras, so that we can see if there's a child in the background. Violence as we get older, bullying is a big thing in kids, and children do have mental health problems. As much as we think you don't have a child who's schizophrenic or depression, oh yes, there is. And I've seen some really things, unbelievable children, and their symptoms, and they really needed help. Just some things to show you. Guns are always going to be there. Suffocation, swimming. I mean, I live in South Florida, so swimming is a big thing, and children falling into pools and drowning, getting into somebody's medications, and then of course the stove for sure. Some of the health problems, and the biggest group of children that are at biggest risks are these premature, very low birth weight or low birth weight children. Children born soon are going to have more problems than a child born at a normal time with a normal delivery. If you're in daycare, you're swapping germs. I call it children swap spit every day with toys. One toy to another kid and in the mouth. I mean, that's what they do. And they're always hugging and looking on each other, biting each other. Okay, that causes health problems. In poverty, homeless, it is a real thing. I've seen many children, homeless that are coming in that are extremely ill. So of course, they don't have proper nutrition, hygiene, etc. Immigrant families. I mean, I live in Homestead where there's a whole bunch of, tomato fields and vegetable fields. And we do have the migrants come in. And I'm telling you, the migrant families, when they come into my last job was in an emergency room at a level 4 trauma center for 10 years. And the immigrant children that came in were the sickest of all because they don't want to come. They're afraid of being deported. They have that fear. So they really wait too long. Again, medical, psychiatric illnesses that are just chronic, and then they don't have any access. Just think about that homeless. They don't have insurance, right? They have no money. Those immigrants are afraid to go because they're afraid they're going to be, brought back to the country. So they don't have a car to get to the doctor. They don't have money to get a bus. They don't have money for, just that little deductible they have to pay. And these are real things when you're talking about, it doesn't even matter children or adults. So infant mortality, you think United States would have the best infant mortality. They wouldn't have many infants dying, and we are absolutely behind many other countries. Infant mortality is either neonatal or postnatal. It's basically up to 1 year of age. We talk about infants, and it's for many different reasons. Lack of care when they're pregnant, being delivered, where they shouldn't be, or, nutrition. All of these things are a big thing. And the biggest thing that determines, the death is how big is a kid. I've seen children at the smallest one I saw was 450 grams. 1 pound is 554 grams, less than. The head was, the size of a quarter almost. And actually that kid made it, believe it or not. Now, could have issues, medical problems, but the kid did make it. Death rates for children are the bigger ones, but as they get older, their death rates are less because now they're healthier. They made it through that first year. But what is that thing that causes mortality? It's just think about toddlers. They have no fear. I call them the dive bomb kids. They'll jump from the couch to the chair, miss it, head hit floor. Now they have, a fractured skull, intracranial bleeds. I mean, all of these things happen. As they get older, they get smarter, the school age, 5 to 14, but then you go to the adolescence and they start to get a little bit, oh, I can do this and that, and they get in with the wrong crowd, injuries. They're doing things because they feel they can, because they feel they're old enough now, and because of in adolescence, one of the biggest concerns is body image. No teenager feels like they're pretty enough, small enough, big enough, freckles enough, hair color enough, and this body images leads them to depression and suicide. Now, children, when you're talking about them, one of the things that's the center of them is family. Whatever the family is what that child does portray, that social, the cultural, and the religious influences. It's all about family. Family-centered care is pediatrics. Family-centered care, it recognizes families as the constant in the child's life. That means that's what they know. That's all they know with food, the way they talk, the way they dress, the way they act. It's all the family. What they believe in, their culture, their religious, is all about the family. And what is the definition of a family? It's whatever they say it is. There are many families. You have grandmothers as parents. You have single parents, single mothers, single fathers. You have aunts raising children. You have families that are large. We have mom and dad and grandma and grandpa and aunt and uncle and cousins all in one place, in one home, because that's the way they have to live to make, ends meet. And that's what the family is. So families are all different. So one of the things in pediatrics that we've been doing is to provide what we call traumatic care. I think children, one of the things they're afraid of most of all is needles. And as they call them down here, no pinchies. I work, in South Florida with a large Hispanic population, and all the children are yelling, no pinche, which means no shot. My dissertation of my doctorate is children's attitudes and school-age children's attitude and behavior towards injections. You have some children who are not afraid, and you have many children who will get up and run in the opposite direction because they're scared. And it's because they've been hurt somewhere along the line. So now we've decided and understand that if we decrease or minimize the amount of pain, these children will be more apt to be willing to get the procedures done that they do need. So it reduces the stress psychologically, that their physical distress, they're not going to be screaming and yelling and a heart rate going up and going crazy. And it's always first do no harm. You've got to get the procedure done, but let's do it in the way that it's not going to hurt. And as I said, family structure is all completely different. Now, culture, you think culture, does that really affect the way children or even adults, the way that they accept medical care? And yes, it does. We know that there are some religions that they have to have their special foods, their special clothes. They need to have the prayers and stuff involved in their care. And we must, as healthcare professionals, allow the family to practice their cultural beliefs. And we let them practice anything as long as it's not going to hurt the child. Now, one of the things that I have seen that I didn't understand is Hispanic people. You get a little child in, let's say a 2-year-old comes in the emergency room and they have got a fever. And grandma, abuela is what it's called, has a child wrapped in a blanket with a hat on and socks and holding them tight because they've got a fever. So I say, why do you have him wrapped up? Just because he has a fever. So you need to describe what a fever is all about. So you say, well, if you wrap it up, the fever stays in, it can't go away. So let's take it off so the fever can go away. Another thing is they don't like them to walk on a floor without socks or shoes on. They think the cold from the floor is going to make them sicker. So I'm like, well, if you have a fever, one of the places where heat comes out of the body easily is the feet. So if you let them walk on a cold floor, you're decreasing that fever just by applying cool to the feet. And they're like, oh, okay. And now when I'm describing this, I usually will be talking to the parent or to the child, but I'm literally speaking to that grandma, because it's usually the grandma. Ever hear if you go outside and it rains, if you get wet, you're going to be sick? Well, these are all those beliefs that are out there. And if we're understanding our child and our client, that these are things we need to understand. Now, there's other religious beliefs that do impede upon the medical practice. Well, number one, natural remedies and medicines. Now, there are some cultures. My husband's Jamaican, and one of the things that he likes is a lot of teas. Some of these teas can affect blood coagulation, or some of these teas can damper their immune health, or there's many different things with it. So we need to know the culture so we know what questions to ask these parents so that we can take care of that child better. Another one is blood products. Now, I have run into several cases where I have a premature infant who has, now remember, they do not make blood by themselves. They do not make cells up till over 3 months old. So if we're taking blood for specimens, that blood's not being replaced. So those hemoglobins and hematocrits go really, really low, and they become what we call symptomatic. They're going to have periods of apnea and periods of bradycardia. So they need blood. Now, what if this patient is a Jehovah's Witness? They don't believe in blood. So in this case, we will be asking for a court order, and then we need to give the blood. Now, you as a nurse, how are you going to give blood to this child without upsetting these parents? Now, they know this child's going to get the blood, but you don't have to have that blood up in their face. What I mean by that, I've done it on the day shift and the night shift. If it's the night shift that I'm giving blood, I wait, if I can, till the parents go home. And I will do it then, let the parents know I'll do it, when to call me to let them know, because they want to know if they had no problems with it. On the day shift, I'll have them step out of the room and I will put it up, hook it up, start it up, but I'll cover the pump and cover the tubing so they don't see the blood. And that empty bag of blood is not going to be hanging around so they see it. So I've respected their culture and their religious beliefs, but the child is still getting what they need. Now, pediatric nurses are, I think the person, we should be paid more for therapy sessions. You have not only a child, you have a mother and a father. And sometimes even with parents who they're fighting because you have a chronically ill child, and now you're in between the mother and the father, because now the child's getting upset and you don't want that. So we are in an amazing relationship. I can tell you today, I have relationships that are 20 years old from parents that I've helped through situations. And I've also had relationships that long with parents whose children have died, and they still, on my birthday, will send me a message, happy birthday to Chris's favorite nurse, or happy birthday from Olivia's favorite nurse. Or it's amazing the relationships that you can build. I mean, nurses, we have that, that caring for the whole family. In that role also, we make sure that the parent and the children know how to take care of themselves, and we encourage it, and also injury prevention. We know that, as I said, a lot of stuff is counseling, but what if you have a critically ill child who's going to go home and needs an abundance of medical care continuing at home? Well, we're going to coordinate that and make sure that they have all of the disciplines they need to help. Many times they ask you your opinion, and you can, if you're comfortable, talk with them. Today, nurses can sit with parents and describe things going on with their disease. It doesn't have to come from the doctor. If you know what you're talking about, you can sit and talk with that parent, and they can ask questions, because who spends the most time with patients? It's us. So genetics. You know, we know that we go from the wound and we go into be an old person, and many things we have to be looking. And in children, we need to know every level and what's expected of these children. So we know the nursing process, the assessment, diagnosis, outcome, implementation, evaluation, and the documentation. It's always you're going to see. So if I was to give you this question, the leading cause of death among African-American boys ages 15 to 19, what do you might think that could be? It's actually the firearms. I think second would be your suicide. Now, children, as they grow, it's going to be what we call interrelated, simultaneous, and ongoing. They grow so quickly in that first year. We have a child who can't lift his head up, can not even grasp things by themselves. It's all reflex at this time. Up to 1 year, that's at birth. And at 1 year old, they're up and they're walking and they're taking things and feeding themselves things. It's amazing how quickly they grow. And next week, we're going to go on all of those things. And we're going to be looking at those developmental stages. It is part of the directional, sequential trends, the developmental pace, and we'll go into sensitive periods and individual differences. As you do your reading this coming week, look at it, and I'm going to go over it more next week. Growth and development, metabolism. Well, children at birth cannot maintain their own body heat. So we need to keep them warm. We need to keep them covered. Thermoregulation. They need a lot of sleep. Now I'm going to be sending you a handout on vital signs. So a newborn baby, they're born. What is a normal heart rate? Now an adult, 60 to 90, 60 to 100, right? An infant, 140 to 160 at rest. That is normal for a heart rate. And a respiratory rate is 40 to 60. And that metabolism, what that is, it's going to get lower as they get older. By 1 year, heart rate 100, 120, respiratory rate could be 20 to 30, and it decreases, decreases, and decreases. And always, 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 nutrition is the single most important influence on growth. You know, I've said to many parents, they're like, well, the kid's not eating enough. I don't think we need to feed him more. And I said, well, is he doing all the developmental things that he should be doing at this age? And they go, yeah, actually he's advanced. And I go, well, then he's getting enough nutrition, because nutrition works with cognition. And children from the get-go, from birth, can let their needs known, their temperament. They want something, what do? They cry. And what happens? Somebody comes get them. Now, through all of the developments of infants and toddlers and school age, you're going to be seeing these children. We're going to be referring to all of the theorists. So the two that are the big ones is Erickson, and it is Piaget. You will see a little bit of Kohlberg in there, and I'm going to go through them, and I'm going to try to make you understand what those developmental stages are. When we were looking at the HESI, there were 4 questions on developmental stages that were there only on the last semester, on the last HESI. So knowing these things are very, very important. Who has their speaker off? Somebody needs to go on mute. I can't find it.
Yeah. I mean, we're great at events and non-events. You know.
There it is, right there.
I cannot wait.
All right, sorry. So as you're going through the readings, okay, Erickson, Piaget, Kohlberg, make sure we look at them. Make sure we understand what is Erickson infant. What does those things mean? I'm going to be explaining them, but I want you to know it's important that you also look at it. So children growing, the basics of growth and development is all about toys, isn't it? We know at first black and white toys, they say, and then it goes into colors and noise and sounds. The one thing children do is they like to touch, they like to feel. What does that toy feel like? Then they like in the mouth, the oral, so sensory or motor. So touch it in the mouth and then moving it and shaking it. Sensory or motor development is so important. This helps their cognitive awareness and be aware. They socialize or creative, all of these things just with toys. Now, there are types of play, believe it or not. Do we play that it's organized together, working together to meet a goal, or is it playing together with no goals? All of these things you're going to see as you do your reading. Look at them really closely. You can look at what's going on, play alone, play next to, combined with, or like cooperative play would be doing a board game together, playing, Monopoly as you get older. That's definitely a board game, and there is an outcome. Toys are great because they force a kid to move. They force them to push, pull, roll, and manipulate things and their hand movements and their muscles. And it really is a great time for kids to play together and also for parents to play with them. Now, one of the things we do when we see a child as a nurse, we're going to do a height and weight in every kid. That's also going to look at nutrition. Every time they are visited, they are going to be seeing that, okay? So another thing we're going to look at is developmental stages. So let me give you an example. So you have a child who's in, let's say, the doctor's office, and you're a nurse, and it's a 6-month-old child, and mom says that they can roll from front to back. Okay, well, that's usually what they can do earlier than that, but they can't go back to front. This is a delay in development. So they should be able to completely roll over by 6 months. So if they can't do that, I'm going to ask you why. Is there something going on? So these children can get early intervention and catch up where they need to be quick. Children, infants catch up so quickly as long as they're taught how to do it. And the quicker we do the intervention, the better the outcomes. Some children are born with things that aren't quite normal, club feet. Some children are born without a finger, an arm, a forearm, a leg, a toe. These are all things that can happen. It could be just little fiber bands, run around it and pinch it off so it doesn't form, or it could be due to some sort of syndrome. Could be due to, the mother's drinking alcohol, using drugs. It could cause it, or it could be from rubella, exposure to that radiation. And then there's a metabolic, the PKU thing. And in these genetic disorders, this 22 pair of chromosomes could be a 22q deletion, which is actually what we call a DeGeorge syndrome. And what would you see in that? And there are differences. And we're going to go into some of the syndromes. You're never going to know all of them. And I'll tell you, I've seen syndromes that I've had to go and look it up because I've never seen it before. That's how many there are. So our goal as a nurse, what are we going to do? I think pediatrics, a lot of our stuff is, giving that love, that attention, that care, but education, okay? And doing it on that child's developmental level so that they can understand. And then also supporting that parent. You have a child coming into the emergency room. It's a 1-year-old child who's had a fever for 5 days, and they've been to the doctor's office and the urgent care, and now they're to the ER, and this child still has a fever of 104, and it's 5 days out. Now, as a nurse, the first thing I'm going to say is, you must be exhausted. Wow, you've done this already? Okay, let's help you. And just acknowledging the fact that this parent is exhausted because their child has been so sick is going to help that parent relax, because you've identified one of the biggest things. I got to rest. The kid needs to rest. He needs to get better. So you've identified that already. So a father tells a nurse that his child is filling up on the house of collections. They have seashells, bottle caps, baseball cards, and pennies. Well, what is that all about? Well, you're going to see as you start reading is this is what children do. They like to have collections of things. And as we look through, you see, and these things are here. It's called concrete operational thinking. And what it is they know that there's similarities in certain things and that they can put those similarities together, like all the cars, all the trucks, all the blocks, all the letters. They're able to do those sort of things. So, oh, actually, I put this here. I forgot I did that. So anyway, these pre-operational thinking, object permanence, these are things you're going to see again, and I'm going to explain them again. The one thing that's important to remember is this object permanence. You know, children see a toy and they grab to get it, and you put it behind their back. And even though it's behind your back and they can't see it, they still know it's there. That's object permanence. Or you take the toy, put it back in the toy box. The kid can go over the toy box and pick it back out because object permanence, they still know it's there. So communicating with children, communication is so important with children. And again, get on the level of the child. I like to sit on the floor or the bed next to them. Remember HIPAA, very important. You know, and again, you always introduce yourself properly. Who are you to a parents? And parents. Now, one of the things I've heard many nurses say, and even students say, the hardest thing with pediatrics is that the children come with parents, and the parents are more difficult than the child itself. And I'll tend to agree with you, but you can make that parent your biggest supporter in doing your job for you if you teach them properly, because that's basically when parents are that overwhelming, they just want to be a part of that child's care. So as you're talking with a parent, make sure that you keep the focus onto the question you want. Just, you know, I'll give you an example. You get a child in, they come into the, say, being admitted to the hospital with a fever. So you say, so tell me about your child fever. Well, they're going to tell you what happened at birth. The kid's 8 years old now. They're going to start about birth, what happened here and there, and no, what happened this time. So refocus it. Focus onto what you want. And remember cultural awareness. There are cultures, they don't want you looking in their eyes, or they don't want you to touch them, and they need their spaces. So being aware of culture is very, very important. Being empathetic, like I was with the mother with that child with a fever, very important, because now you've actually gained that parent's trust by showing that. And if you have a child and a parent who don't speak your language, do not get an interpreter through a family member. Make sure you get one that's appropriate, whether those blue phones or one of the nurses or whoever who work with you, because they're going to put their own interpretation on what they're saying. There's all ways to talk. You know, you have children that can't speak, but they're going to be able to express what they want. Again, always go on the level of the child. Now, this is one thing that I had to work with a lot. You know, Hispanic people at the time before COVID would go into the emergency room and there would be 8 people with them, with one child in the Hispanic culture. It's just what they are. They love their kids, they love their family, and they're supportive, which is great. But you're going to have 16 people talking to you when you're asking a question. So find out, who am I talking with today? Who is the one who's been caring for this child? And then, you know, the other people know that only one person's talking, because if 10 people are talking, you can't understand what's going on. Find out what's going on this time, this chief complaint, and this illness. Birth history is just whether they're premature or if they were, you know, on time. Eating, do they have any problems with eating? Any allergies, for sure? Any illnesses that can, you know, open your eyes to maybe what's going on this time? Any medications today? You know, Tylenol and Motrin is important if they've had a fever. And then if I have a kid with a fever, one of the first things I do want to know is their immunization status. Are their immunizations up to date? Because that will, if they are, then it will stop me thinking of some diseases that could be, the immunization, make sure they don't get. So make sure you know the immunizations. Are they up to date? Are their growth, are they where they should be? And then habits. Why habits? Well, if you're admitting children to a hospital, you need to know that, let's say sometimes a parent has to step out, go talk on the phone or something. The kid's screaming in the room because their blankie fell on the floor, because they have to have that blankie or they're going to start crying. Or maybe it's a little toy. I mean, my grandson was Mr. Puppy, which is funny because it was a little giraffe that he called Mr. Puppy. So if that was on the floor or not in his sight, he'd be screaming when he was 2 years old. So habits are important. Or do they like their pacifier? And which one do they like? Because you can always help this child relax. As you get older children, you're going to be asking about their sexual history, which is absolutely fine. And, with adolescents, you're going to say, can you talk about, sex and birth control? Well, yes, you can. But we only give information, not our opinions. And we like to do it also in written form also, giving them a pamphlet of something that they can work with. And remember, with families, you don't always assume it's the mother you're going to talk to. It could be the grandmother, or in some cultures, it's only the father. How are they doing in school? Tells you a lot about a child. Are they just barely getting by, or are they the A and B kids? Unusual habits. Do they do things that are not like other kids? And then watching how the parent and the child interact. I think one of the things I would see is, in our emergency room, the last position I had, there was a door. So they would go into the room and close the door. In the room was a stretcher, a little nightside stand, which had some gauze and some alcohol and some culture tips there. And on the wall was, the otoscope and listening to, looking at the eyes and the ears, all in that thing with the little black little things. Many times I'd walk in and those little black ear tips were thrown all over the room. The gauzes were on the floor. The drawers were open. The sheet was off the stretcher, and the mother's sitting there on the cell phone. So does she have control of her child? No. When you're looking at the body, you do, each system, but of course, your focus is going to be, what's going on now? Is it a cough? That's the first thing I'm going to do. If an infant is sleeping and they're complaining that there's a cough, I'm going to listen to those breath sounds and heart sounds in the parent's arms when they're asleep, because I can hear it. They're not crying. They're not fussing. I want to know what they eat. I mean, would you like to give somebody who's a vegetarian a platter of pork for dinner? No, they'd be very insulted. So make sure you know cultural foods, and then of course, looking at the nutrition. Is it okay? And if you don't know, we have dietitians. So the first thing, as I said, height and weight, number one. That's actually looking at your nutrition too. If they're gaining weight, they're gaining height, we know that they're getting proper nutrition. When we're talking infants, we like to measure their heads. Remember the difference between a head and a chest of a newborn infant, and then when they get to be 2 years old. Now, when they're born, they have big heads. It's bigger than their chest, right? But by 2, they should be equal to the chest, or the chest should be bigger than the head. And if they're not, we need to tell the physician, because something's going on. Is it maybe hydrocephalus all of a sudden, or is it a brain tumor? So these measurements do tell us a lot. Remember, vital signs change for each child according to how old they are. So we will be doing that. And there's something that we do, we call it general appearance. Looking good or looking bad. You can see a kid from across the room walking, bent over, holding their tummy, looking pale. That kid looks sick. That one looks bad. Okay, but the one running around the hall, that kid looks okay. Lymph nodes on children, You should not feel lymph nodes. If you're feeling them, the child is sick. The lymph nodes should not be there at all. And again, we're going to go through everything. And then looking first at things is first, always inspect by visual first. And then you auscultate, palpate, and percuss. Those things we do last. And then genitalia, there are girls and boys, but I'm telling you, there are different things that can occur to genitalia. You can have fused labia on little girl infants. Their labias are fused tight, and all we do is some steroid cream and it opens it up, but this can happen. You have males, are they circumcised, uncircumcised? Can you pull the skin down? We also have ambiguous genitalia where they have some of both, and we'll get into that too. Looking at the anus, no, number one, do they have one? There are times where infants are born, they don't have an anus. That's why you do a rectal temp, not only to measure their temperature because it's accurate, but because making sure they have an anus, and then looking at the rest of them and all of their reflexes. Many times, children, the younger ones, they can't stand. So we'll draw lines on the paper, on the stretchers, or even the sheet if we need to get an accurate height. And you think taking a height on a child is easy. They see that big board coming down over their head. They think it's going to whack them. So you got to make fun with it. So number one, I do it first and I hold it and I go, oh, look, my number's 7. What's your number going to be? Here, help me with it. Turn around and we make a game out of it. Like, oh, wow, you're number 8. You beat me. Now, what have I done? I've made it fun. It's non-threatening, but most of all, I've got the information that I need. Blood pressure cuffs can be a 00 up to an extra large. So pick the right blood pressure cuff. Didn't think about that, did you? And it could be on the arms. It could be on the upper arm, lower arm, upper leg, bottom leg. I like for toddlers, number D, because I can hold the leg and it doesn't hurt as much as the upper arm. And they can't see it. But also with these electronic things, I said, you want to push the button and do it yourself? Can you help me? And I'm telling you, they'll push it and they'll have fun. And I go, oh, wow, you got big numbers again. Again, general appearance, looking through them, going from top to bottom. Again, start with the focus and work from there. And then our last chapter of today is pain management. Years ago, we didn't worry about pain in children. We figured kids don't have that much pain. We also said, well, they don't need a big dose. They just need a little of something, and that will help. Well, I'll ask you a question. If you're an infant who just had open heart surgery, do you want to have real pain medicine or just a little bit to help you? And the answer is you want exactly what you need to help you, because children do have pain. And the other thing about their pain is because they're afraid of that pinch, that needle, they're going to say, I'm not in pain. No, it doesn't hurt. And you can tell they're hurting. So making sure that we give pain medicine, we do an appropriate pain level on them. I'm going to go into that, and that we do not wait too long or wait too long in between or too long to give it. Just like adults, we treat these children and give them adequate pain control. And remember, it's just not the medicine. It's also maybe putting on some music or giving them a game to play or to color. Those things help also. There's all different sort of pains, just like adults, same thing, chronic, recurrent, persistent. Children, ear aches, probably one of the biggest pains that they do get. They're crying, just holding their ears. It could be braces. It could be a appendectomy. It could be a little bit of anything. So one of the pain scales we use, this is the FACES tool right down here. Now, FACES tools are not used until the child becomes 3 years old. You need to know what pain scale is an appropriate one. So 0's no pain, 10's the worst pain in the world, which is numeric for adults. but we have faces for the kids. These are different sort of pain things. The ones that you need to know is FLAC, faces, and numbers. Those are the three that you will see universally used. So the cries is a one-on-one, sort of like your pain control, but faces, preschool age and older. So it's going to be at least a 3-year-old kid. Preschoolers are ages 3, 4, and 5. Numeric, they say 8 years of age. Now, I've had children at 4 can tell me a number, but according to the book and what you need to know is numeric is 8 years old and older. Now, we do have some children, let's say you have a child who has cerebral palsy and they're 18 years old. And this child can't talk to you, but you can use something called a FLAC scale. And what it does, it looks at the child's face. Are they grimacing? Which you can see are crying. Their legs, sometimes you'll see them moving because their tummies hurt, right? Or they're not moving because they hurt so bad. Or, and the biggest one is consolability. Are you able to console the child? We use this for infants. We use this for young toddlers and for those nonverbal children that are older who do not speak. Those are different sort of pain scales. Oh, cultural differences. I've had many a father tell me their sons don't have pain when they have a fractured arm. They say, oh no, he's fine. Tough it up, you'll be fine. And I'm like, have you ever had a broken arm? Let's give him something for pain, please. So I mean, it could be Motrin, but it could be morphine, whatever, depending on the break, right? So cultural differences, make sure that we are that advocate for our children to make sure they get the medicine that they do need. And as I said, there's other things besides just giving pain medicine. We can distract them. Distraction, I like music on, or the TV on, or, you know, playing a game with them, or cards, or giving them stickers or something away from that pain. And it does help them. In infants, one of the ways that they do soothe themselves is through a non-nutritive sucking. What's that? It's a pacifier. Oral, anything in their mouth tends to decrease their stress. So infants screaming and yelling, give them a pacifier. They do actually on boy babies, circumcisions with a little bit of sugar water on a pacifier in the mouth during the circumcision. And these neurophysicists by Harvard, there is a research study that says it acted just like morphine. And there was no difference in level of pain between given morphine and the pacifier with some sugar on it. And then the other thing is kangaroo care. This woman here has this baby against her bare chest. I've seen little premature babies just absolutely irritable and just crying. Put them on mommy's chest, their heart rate comes down, respiratory rate comes down, and they go to sleep. It's quite amazing. And pain medicine is just not the opioid, it's just not that morphine. It's also Tylenol, and it's ibuprofen, and there's, you know, different ways to give it, but we can alternate that. Hot packs, cold packs, all of these things can work. We can make sure children's pains are treated, especially those children who have long-term problems, let's say like sickle cell. You know, if you have a child with sickle cell disease and they're in crisis and we don't adequately take care of that pain, all that child remembers from the hospitalization is that they hurt. So if we turn that around and make sure that child has decreased pain for the next admission, they're not going to be as scared and as stressed. And this actually can help the child's, you know, outcome. As I said, there's all different ways where you have pain, teething, immunizations can cause pain. I always suggest giving Tylenol the first 24 hours after immunizations, circumcisions, wounds, any surgeries, etc. And And there's some more things that you can have for pain. And that's that. Those are your first chapters that we've gone over. So now what I do is we're going to do a Kahoots. Has anybody played a Kahoots before?
Yes.
Go to kahoot.it. And I'm going to give you a code.
I want to do it on my computer.
So you need a phone and a computer. The phone will push the thing and the computer will let you see the question. Your code, the first code, 502-6643. How are you all doing so far?
Good.
Okay. Any questions?
I got a question. Are you our teacher or is the other professor our teacher?
Okay, you were sent to me today from Dr. Arstenstall's class because she was having issues with the Zoom.
Okay.
So I am the lead pediatric professor, and I teach at the same time as her. So you were able to have me today.
Okay.
Now, if you like my lectures, I do have a YouTube channel, Professor Bogart's Pediatric Nursing on YouTube. So you can always go there if you feel you learn that way. Whatever works for you. Go to your professor's class, see what she says, come to mine, watch it on YouTube, whatever works. That's what you should do. We as pediatric professors all work together. All right. I think that's good. Well, who's going to win today? Anybody feel like it? Raul, Linda, Yulimar? Sasha Winnett has a heart. I think there we go. Here we go. Pediatric nursing, week one. Wow. It's going to be week 10 pretty soon. From a worldwide perspective, infant mortality in the United States. That means how many infants up to age 1 die. The amount of infants that die.
I'm sorry, can you give?
Okay, the code again is, hold on. It's the highest from all of the nations. It's usually right here, hold on. It's 502-6643.
Okay, thank you.
No, you're welcome. All right, next. We'll see Elizabeth's up top. Look at this, Ashley. Number 2, the leading cause of death from unintentional injuries in children is what? What did I tell you causes the death on children? I mean, we know they dive bomb, they get burnt, they take pills, they find guns and shoot them, they drown, but the number 1 cause. And it's motor vehicle related. Remember, it could be using the booster seats wrong, the car seats wrong, not in a car seat. So during an accident, something happens, or the car runs over them. And I've seen a child get run over with nothing happen. And I've seen children run over where they had internal injuries. So it could be either way. Children are very special. Which statement is most descriptive of pediatric family-centered care? What is family-centered care? So you see how the lecture falls right into this cahoots, and it quizzes you on those concepts to make sure you understand. Yes, it recognizes that family is the constant in a child's life. What they eat, what they dress, what they think, and what they do is all based on what the family does. They don't know anything else. The major cause of death for children older than 1 year is what? Well, we know it's motor vehicle accidents is, that thing, but and it's unintentional injuries, whether it's in the car, whether it's that dive bomb toddler kid jumping off a couch, hitting the floor, and getting a interventricular hemorrhage, all of those things. They have no fear. There's no fear on these children sometimes. The nurse caring for the child in pain understands that distraction it must be developmentally appropriate. You wouldn't give an infant a sticker because it's not going to do anything, but you might take a rattle and shake it and distract them, right? So developmentally appropriate, okay? You're going to start to think that way as I keep going here. In what type of play are children engaged in similar or identical activity without organization or mutual goals? Now, as I said, play is important. You need to understand what they are. It's in your reading. So come back next week and I'm sure you're going to know the answer. Is it playing alone? Is it playing next to? Is it doing the same things? Or is there a goal in the end? And the goal in the end is associative, which means two kids get together, decide on what they want to do, how they want to do it, and how you win the game. That's associative. Which statement best describes the process of critical thinking? What's critical thinking? They've been telling you this since day number 1 in nursing school. So it's purposeful and goal directed. Let me give you another example of critical thinking. So your friends are coming over for dinner and you decide that you want to make spaghetti. So you check your cupboard, see what you have. You go to the store and you pick up the items you need. You come home, you make the spaghetti. So it's purposeful. I want to make spaghetti. I need everything. I went and picked it up, went home and I did it. Critical thinking. Balancing a checkbook. Critical thinking. These are ways that we think critically every day and don't think about it. What is probably the single most important influence on growth at all stages of development? Nutrition, nutrition, nutrition. If you do not feed the body as it's growing, it's not going to grow properly. Nutrition. Frequent developmental assessments are important for which reason? So we check to see, is the infant lifting their head up? Are they rolling over? Are they grasping a rattle? Are they walking? Are they crawling? Are they jumping on one foot? Can they button their t-shirt? Knowing those stages, and we're going to learn them as we go along, because if they are not where they should be, we can say there's something happening. There's delays or deficits, and then what do? We start early intervention, and we can have them catch up really quick. Which function of play is a major component of play at all ages? What does play do? What did I describe to you? You know, toys, love toys. Children love playing with them. The touch, the feel in the mouth, you know, because that's that stress reliever thing, and moving it all over the place. Sensory-motor activities is a part of that creativity that they do learn because of sensory-motor activity. It's socialization because of that sensory-motor activity. Do you see? Sensory-motor activities. 3 children playing a board game would be an example of what? And that is your cooperative play. That is the definition of it, because they're making their goals and getting it done. The head to tail direction of growth is referred to. So that means when an infant's born, the first thing they do is lift their head, and then they roll over, and then they creep and crawl, and then they get to the point on their feet, which is their tail, and they walk. So that cephalocaudal, that is the term that is used for it. And it's the way children progress normally in their development. Somebody's on fire. What is the single most important factor to consider when communicating with children? And we try to make children to do all sorts of things, but just think the first thing we need to do is do a height and weight on these children, and for them to do it properly, because you need accurate information, right? How are you going to get it done? Get on their level, you know, play with them, have fun with them, so that you can get it done easier. Try to force a kid to get on a scale or take a height. It's not going to happen, but get on their level and play. They're going to do it and have fun doing it. What 2-year-old child pain assessment tool should the nurse use? 2 years old. So at 2, they're still at FLAC. At 3, they go to FACES. This is the answers every semester I get for this question. So remember, FLAC is up to the age of 3. FACES starts at 3. Starts at preschool. Preschool starts at 3. At 6 months, an infant's birth weight should do what? You know, I tell you, we're going to measure these children height and weight every time. So we need to know what's normal. What are we looking at? At 6 months, it's what? And at 1 year, should it be what? And if it's not there, what are we going to do, right? So it should double by 6 months, triple by a year. And if you have an infant born, let's say at 6 pounds, and at 6 months, they are weighing 9 pounds, there's a problem. They're not getting the nutrition they need, right? So we need to change their diet and do it as quick as possible, because they need nutrition in order to grow properly for cognitive development. So 6 months, it doubles. The first expected fine motor developmental milestones for an infant begins with. So when you think of fine motor, fine is fingers. And then another one is called gross motor. G, get up and go, 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 as Paw Patrol says. So F, fine fingers, gross, G, get up and go. So the first thing that happens is the Mother takes her finger and puts it in the infant's hand and they hug it. And they go, oh, look, he's hugging my finger. It is not, they didn't do it purposefully. It is a reflex. So the first thing is the reflex. Then it goes into voluntary. They're going to close their hands. Then they go into this, pincer grasp, which is like this, picking up Cheerios. Starts out with a crude one, and then it goes into a neat one. And then later on, about 11 months, they put objects in a container. So these are milestones that you're going to get in your reading this week. So pay attention. An 8-month-old infant should be expected to perform which fine motor skills? So the first is a reflex. Then it goes into voluntary. Then it goes into crude pincher, fine pincher, switching objects from hand to hand, putting things into a container, and then building a block of 2. So by 8 months, it is grasping that rattle, okay, purposefully, and then, doing that little pincer, but maybe it's a couple fingers and smushing those Cheerios into the face. The natural physical developmental sequence that most children follow is what? So physical, what do they do physically? So the first thing they need to do is lift their head. That's number 1. Then they'll roll from back to front, front to back, back to front. Then they'll get up on their knees. Then they'll start to stand up and cruise. And then they're going to walk. And that's all part of the natural sequence. Now, it doesn't mean they can't go from creep to walking. I've seen it happen. But as long as they're going forward in that direction, you don't have to do every step. Frequent developmental assessments are important for what reason? Then I'll ask you, why do you do them? And what do you do if you find delays? You're going to start early intervention, right? Very important concept. That's why this was asked twice, because it does identify those delays and we can institute early intervention, physical therapy. Which behavior indicates that an infant has developed object permanence? What is object permanence? I told you what it was. Put the toy behind your back. So they see a toy, they know it's there, you put it behind your back and they go looking for it. Object permanence is, even though it's, not in visible sight, they still know it's there. So they go searching. Could be under the blanket, could be somewhere. In general, an infant should triple their birth weight at what months of age? We double at 6 months. So we'll triple at 12 months of age. Yes, very good. Now, and then I'll ask you, so if the baby was born at 6 pounds and it's now 12 months and they're 24 pounds, what are you going to do? That's 4 times the amount. That means they're eating too much. Maybe decrease the calories in the food because they're getting too big too quick. Or is there some medical condition that's occurring? Makes us to go look and to examine what's happening. Perform a head to toe assessment on a toddler. Most important to consider before beginning the examination. So toddlers are ages 1 to 3. These are my dive bomb kids is what I call them. I think it's a great age. So before you start, get on their level. Let them know what you're going to do. Let them play with the equipment. Let them touch a stethoscope, push the buttons on things, make it fun, make it a game. And then you're going to be able to get your assessment done a lot quicker. According to Piaget, toddlers are in the blank stage. Now, I'm giving you these examples because these are the type of questions that you're going to be seeing. So as you're going through the theorists, pay attention. Again, toddlers, next week, I'm going to go over more about Piaget. And actually, Piaget is that sensorimotor, okay? In the mouth, they're able to touch and feel and to play with it. They're doing something with it. Which intervention helps a hospitalized toddler feel a sense of control? So you've got a child whose ages 1 to 3, and they're put into the hospital. Let's say they need to come in for, some testing for several days. Now we know toddlers don't like that. They want to be home. What can help? Put them on a routine that they're following at home. Have the same food, same bedtime, same bath time, same nap time, within reason if we can. And that makes them feel comfortable because they know what's coming next, because it's the same as home. It's nothing different, just different bed. All children can reach developmental milestones at the same age? Yes or no? Absolutely not. You have children that at 9 months old are walking. And then you have my children that never walked, but at 15 months, all of a sudden they ran. So all of them are different. As long as they're moving in the right direction, that's okay, within reason. So no, all children are different. They're all different in the way they reach these goals. This is why I like pediatrics, because they keep me thinking. Immunizations for a 4-month-old infant. What action should the nurse take to provide traumatic care? What do infants like to keep them calm and stress-free? Decrease pain. They're getting immunizations. It hurts. Give them a pacifier, right? Pacifier helps them relieve their stress, decreases the pain, and it's the best thing for them. And then if you can, put them in the mother's arms, which is even better. So they have the comfort of the parents before, during, and after the injection. Which of the following immunizations can be administered to a newborn? Now you're going to see a 2-page list of immunizations for children, and you're going to say, how can I remember all of these? Well, you don't have to remember all of them, but you need to know what the first one is. We usually give it in the hospital before discharge. And it's hepatitis B, okay? MMR, polio are later, and DTaP is 2, 4, 6 months, but we'll go into that. You don't need to know all of them, but you need to understand that we give them quick, and we give them in groups because we want to give that child as much protection against these diseases as possible. And these immunizations are that protection because they're born and their immune system is only mom's, and it only lasts for a certain amount of time. So that child needs to build up its own immune system to fight. The normal heart rate for an infant is it's 140 to 160, and that's at rest. That's not crying. You can have an infant crying and have a heart rate of 200, and it's absolutely normal. But respiratory rates 40 to 60. But if you see a respiratory rate of 80, that child's in respiratory distress. So these are important to know. I'm going to give you these handouts. I'm going to send them in a message later on today. What is the preferred site to give an injection to an infant? And it's your vastus lateralis. It's in the outer thigh on an infant. They don't want you to give it, you know, in the buttocks or the arms till later on. But vastus lateralis is where we give them. And then we take the legs and we pump them so that we get that medicine mixed around in there so they don't get this really big inflammation, because they do. The death of an infant under 1 year old with no known cause is called what? And they think that this is caused by putting children to sleep on their bellies. So they now have a program called Back to Sleep, which means an infant should be on their back in order for them to go to sleep. And they can't even be on their sides because they re-inhale their air, and that could cause SIDS death also. So Back to Sleep is what we've been doing for the last, about 10 years or more. They've been into this Back to Sleep, and the amount of SIDS death has decreased drastically. The Vietnamese mother of a child avoids eye contact with a nurse, considering cultural differences. Why? Why does she do that? Does anybody know about the culture of a Vietnamese person? And I'm telling you, you don't know all cultures and all the things. So when I don't know, I ask. And I'm telling you, parents and patients would prefer you to ask. And what this is with the Vietnamese culture is respect. They don't look at their eyes, and that's what they know as respect for the nurse. So if you were to ask, she'll tell you. But if you don't ask, you'll never know. So I'm always asking, and they really like that. A child from Mexico is hospitalized for a serious injury. The father says the child is being punished by God. Why? Why does he say that? And Mexicans feel that this is a belief that children or anybody who has these illnesses, that they are being punished. It's their cultural belief. So understanding that will help us be able to take care of this family and to let them know that, you know, it doesn't mean they're going to believe you, but you as a nurse understanding that will understand why they're thinking the way they do. Which term refers to times in an individual's life when he or she is more susceptible to positive or negative influences? Positive or negative influences? And this is called sensitive periods. This is part of that one slide I was showing you, developmental pace, sequential pace, sensitive periods. This is one of them, just pulling it back to you for you to see. What is characteristic of the pre-operational stage of cognitive development? This is Piaget. Again, showing you Piaget, what sort of questions you're going to see as you go back and look at it, what you need to understand. And I'm going to send you a handout on your theorists too. So you're going to have vital signs and theorists that you can review this week. And now you know why. So pre-operational stage is thinking is concrete. They only know what they can see. They can't rationalize it yet, okay? All they can know is that ball is blue, okay? They don't know it bounces yet until they bounce it. This is concrete. And last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? What does a preschooler understand? Ages 3 to 5, preschoolers. So this talks about all actions are either good or bad, and there are a consequence to each action. You know, having a 5-year-old grandson in the house, he'll go to the freezer, get out a icy, popsicle and eat it. And I'm saying, and who told you could have it? Nobody. Well, it was a bad thing to do, but the consequence was he ate it. So, all right, he had a timeout for 10 minutes, big deal. But he got the popsicle, okay? Good and bad and the consequence for them. So I'll be telling you a lot about trying to teach you, with little examples. Marjorie, good job. Whoop, whoop. Number 2, Elizabeth. Number 1. Me, I won, yay. Number 4, Megan and Ali, good job, guys. So what I want you to do, sign your attendance attestations, please. Do not forget, all right? Any questions for me at all? Anything I can help you with? I'll be posting these by tomorrow at noon, and you'll see my YouTube channel. If any of you are weak on dosage calculation, I've got an extremely simple, less than an hour video on it. And if you need help with it, I'm actually very good at it to help you understand it, for your exams, even your mics per kilo if you need that for med search too. Okay. Nice meeting you all. Have a great evening.
Thank you.
I'll see you next week. Any questions, just message me and I'll get back to you.
Okay, thank you.
Thank you.
No, you're welcome. Take care, everybody.
You too.